Hello, I'm Dr. Alf Garbett, Vice President of the Rehab Council. This video is being shot for our members that will be attending the brain injury lecture that Dr. Gerald Simon and I will be putting on at the 2017 Symposium in Orlando, Florida. So I'm shooting this to review some of the exams that I think people should do, that unfortunately a lot of doctors are not doing to screen for concussion and cerebellar dysfunction. And I mentioned cerebellum because about 90%, I would correct that, half of the neurons in the brain are in the cerebellum. And it's one of the easier things for us to test. Now there can be other areas that may have dysfunction going on from a brain injury, and there's different exams we can do. A lot of the tests I'm going to show tend to focus on that. Some of them will cover some other areas. But this is just some screening you can do. This would tend to be like after you've done some other exams. But I think some of these can also pull out day to day. Like the patients I'm treating with brain injuries, I will do 2 to 4 of these on every visit to kind of monitor are things improving. Because what can happen sometimes is the whole cerebellum could be downregulated or inhibited because of the injury. Or you can have one side normal, the other one that's inhibited. And you'll find positive findings just on one side. But if you're doing the correct rehabilitation, neuromuscular re-education, that's going to be improving. So where they were in balance, standing, it gets more stable. Or some of the misses they may be doing with finger to nose, finger to finger, will be improving. So these are some of the things I quickly can do every visit and to be monitoring. One of the big problems with these brain injuries is they're not looked for. I don't understand why doctors don't check it, but every car accident case comes in. I don't care if they said it was a 5-mile-an-hour fender bender, I scream. Because about 4 out of 5 times I find indications of some brain dysfunction in people. So things are getting missed, and I don't want to take the chance who's going to automatically get better and who we're going to find out 5 years from now still have a deficit because nothing was done about it. It's not worth it to that patient to just ignore it. So I recommend we screen them all, and if there's nothing there, wonderful. If there's something there, then do something about it. And part of the lecture I'll be doing will be concentrating on the nutritional aspect of inflammation of the brain. And then Dr. Simon will mostly go over some of the rehabilitation, and I will be mentioning some of the things that I do that are successful also. So document, that's a key thing. If it's a med-legal case, documentation is extremely important. A lot of cases get beat up in court or by insurance companies because a doctor didn't document properly or at all. So you have to do it. I'm creating some exams I'll have in our excuse me, I'm trying to cover so much so fast here. The flash drives that we'll be giving will have some questionnaires and exam forms that I've put together to help you get through things easier and keep track of it. So that will be part of that. Some of these things I'm not going to mention in the seminar because we're going to be limited on time. I could lecture all day, I mean literally all day on brain injuries. I've got 2 hours, Dr. Simon's going to have an hour. So I got to cover a lot, and our PowerPoints will cover many things. So exam, do your history, do your other exams. Then we do simple neurology. Now some of these are familiar, but see, I'm nitpicky about them, and that's why I find stuff. I think doctors, especially MDs, they're looking for very, very gross findings. Like saying doing finger to nose test. They're looking for somebody touching here. They don't, a lot of times they missed here, a quarter inch off. That's still dysmetria. So I recommend you really be nitpicky. And we look for patterns. If a person, the only finding was they missed the tip of their nose here one time, I may not make a big deal about it. But if I have other indications on this side, then I'm going to look for cerebellar dysfunction on that side. The cerebellum is going to be kind of the switchboard. It's not sending out direct motor control back. It's coming in, interpreting what's going on, and then sending it to the motor cortex on the opposite side. So we have information coming in, maybe through the posterior or dorsal columns, from the mechanoreceptors and proprioceptors in the extremities, This information's coming in, gets sorted out and sent to the appropriate place in the sensory or motor cortex. So it's coming in, so it's going to have to do with fine motor control, coordination, motor learning, things like that. Does not directly cause motor dysfunction or deficits or weakness. That's other things. However, you can have layers here. And again, that's where I think doctors can get thrown off, that they go, oh, it's weakness, it's definitely got to be this. With concussions, it can be multiple parts of the brain have been hurt. Inside of that skull is very rough. If any of you really looked at old, dried skulls anatomy, it's rough inside. The outside's smooth like my bald head, but the inside is rough. And that brain is like jello, basically. It's, it's just, if you put it down on a fresh brain on a lab table, it's going to start squashing down a bit. It's not real hard and firm. After it's been fixed with formaldehyde and stuff, it's going to harden up more. But it's soft in there. It gets hurt. Part of it, gets damaged, is going to be the glucose metabolism. The circulation's going to get affected. The microcirculation in there. The calcium ion-dependent channels get disrupted, and free glutamate comes in and aggravates things. It's a neuroexcitant, which I'll get into that in my lecture in Orlando. But these are things that could chemically disrupt what's going on there. That's where these SPECT scans and the functional MRIs can come in and be handy sometimes to actually show you what's happening there with circulation and the chemistry, the metabolites to some degree. Gross MRIs are looking for the anatomy, and a lot of times you're not going to see much there because it can't see these fine axon injuries, diffuse axon injuries. It may not show that. Hopefully in the future we get more sensitive MRIs. But our neurological testing can pick things up. Too many times I get patients that have been in an ER or something and they never did any exams, even though a person said, I hit my head in the car and something like that. Don't always have to have a direct head impact that happens. Just that quick snapping is going to cause an injury inside the brain, or the brain stem gets injured. With football, a lot of times you see the head snapping, and that's what damaging the brain stem and a guy's unconscious. Maybe it wasn't so much up to the brain, but it could also be that. And with my martial art background, I've studied knockouts a lot. I've watched so many films and stuff, and a lot of times I think it's the brain stem that gets shocked in what's knocking a person out, because that has the conscious centers are in that area. So we may have to do some kind of testing in those areas too. But again, this screening here. So one of the things I'm going to start with, the person's going to be finger to nose. Now, I've learned to start using the little finger. I find sometimes you'll find more findings than doing the index. So I would ask the patient to use the little finger. And the way I explain to them is take the tip of your finger and touch the very tip of your nose. Don't tell them just touch your nose, because they may generally go all over the place. Give them the command to touch the very tip with their fingertip, and when I ask you to do it again with your eyes closed, touch the two same points. And don't let them do here. Like, that's a problem I see with this sometimes, is they're doing here one time and then they're doing here. And a doctor not paying attention will think it's fine because somewhere along the finger they touched, but they pass pointed. If I did it with my eyes open here, but I'm doing here, that's pass pointing. That's dysmetry. It's a positive indicator. So you got to watch for things. So first I'm going to have them say, touch this, get it orientated. And then bring your arm out to the side. Now close your eyes and touch the same spots. Be careful. People will unintentionally cheat. They'll bring the arms down part way, so they're creating a short distance. Don't let them do that, because you won't see some things. Get them out here, coming this way, or way down and coming up. But again, get that distance in there, not the short stuff, because they're going to cheat like that. Again, people will compensate inherently sometimes without calculating it. So we're looking, if it's a quarter inch off, to me, that's dysmetria. It gets recorded. Now, if that's the only thing, again, you forget it. But if you get other findings, they're all looking at patterns. So I'm having them do that, both sides. And then having them do finger to finger. And again, look at it and tell me once you touch those two same spots with your eyes closed. Now move all the way out, close your eyes, and come together again with that. Watch. They're here, here, or if they're coming in and all of a sudden they're fishing for it, that's dysmetria, a form of it. And same way here, they're coming and they're going around like this. I don't care if they finally touch it, but if they were going around hunting, it's still off. So you got to record that. And you can even put that in your note. You know, toward the end of motion, the finger was moving around trying to find its target. You know, however way you want to word it. And that way in the future, there's maybe less and less of that if you're doing the right rehab. So it's going to be, you know, finger to finger to nose, and then have where the person's going to touch with their eyes open, their nose and your finger. And explain to them, I'm going to have you alternating, touching your nose and then touching my finger. And then you're going to move your finger around in different locations. We want to see if they miss at the end, if they come out and there's some swaying, trying to touch your finger. So you're not trying to trick them by moving too fast. You're going to like move and they touch here, then come over here, and maybe do these different quadrants and having them reach around and doing it on both sides. Again, looking for missing or coming out and shaking at the end too. That's a positive thing. Tremor at the end of the motion. That's a positive finding. Now it's different than resting tremor with Parkinson. You get your pill rolling tremor with Parkinson's. That's different. This is where it's, you know, voluntary tremor at the end of range of motion. That's one of the ways you could record it, that they're doing that. That's a positive indication. The fine motor skills off. That's going to be cerebellum. Now some of these things may have multiple areas of the brain. Again, we're looking for patterns. So fine movement. In one of the questionnaires I'm going to give you, he's going to ask the person, are you having more difficulty using a spoon or a fork since the accident? Again, fine motor control. If they're like little, they have to be more careful like that. So those are some of the things we want to look at. So again, say you have them sitting down with this part of the exam. And then you could also have them put the arms out supinated, and then ask them close their eyes and watch. Do they start drifting? Okay, that's going to be a cerebellar problem on that side. You know, a lot of these are going to be the ipsilateral, the same side cerebellum. So if that arm starts going down, that's a positive finding. And then you can do a rebound. Have them hold out. Say, I'm going to press down on your arms, and I want you to try to keep your arms where they started. And with their eyes closed, you push down and see if they bounce. If they bounce way beyond where they started, positive finding. But if they just bounce back up in that area, cool. But do both sides on that. Then standing up. We're going to do a series of tests that are either include Romberg or similar to Romberg. Having them put their feet together. Now, I like to look at things like this as a reference point for me. Either when I'm facing them the other way, I have a large photograph on the wall with a nice big wooden frame. I use that as my plumb line, or use something like this as a plumb line. Because you could get thrown off a little bit. They may be swaying a bit and you're not picking it up. So I have a reference point and I will watch them. And first I kind of look to see where they are and put their feet together. If they have trouble standing with their feet together, that's cerebellum. Even with the eyes open, that's a cerebellum. It's not a Romberg test, but they'll be recorded. You know, difficulty stabilizing with feet together and eyes opening, shifts to one side or the other, or falling backwards. Again, also in your exam, you got to see maybe is there an extremity injury too. Car accidents, for example, a lot of times someone hurts an ankle or a knee. That could be throwing things off too. So again, you got to take all that into context. But recording this first. Then I'm going to ask them, okay, I'm going to have you now close your eyes. I say, I'm going to protect you. You know, I'll put a hand in front of their upper chest and their back to catch them in case they fall. If you're dealing with somebody large, and you may have trouble with them, get like somebody in there to assist you with catching them if they happen to fall over. Because I've seen some people like drop right away, and you had to really catch them. They could be so thrown off. But most people are going to be a little bit swaying one way or the other. So we got our classical Romberg, where we're looking for A to P sway. And that's going to be our dorsal or posterior columns are dysfunctioning. Now, some people are going to shift to the side. That's a little different. That could be cerebellum involvement, or what they call parietal shift, sometimes a parietal involvement. But cerebellum. Later on I'll go over what some of the findings mean, and then in the lecture we'll go over things in more detail. But again, that's where we're looking. Are they swaying to the side? Are they doing figure eights? What are they doing? But again, our classical Romberg's A to P, excessive. Really pay attention to this, because this is one I use a lot of times. Then the added point is I will tell them, okay, I'm going to ask you to close your eyes, and then I will tell you to clench either your left fist or your right fist and see if you feel more stable. And many times they'll be more stable when they clench the fist. So I'll say, close your eyes, and I watch them. Because I've also seen some people can't tell what's happening, but I can visually see they become more stable. They don't sway as much side to side or however, grabbing the fist. That's putting more information into the cerebellum when they're clenching their fist. It's putting more input in and upregulates the cerebellum that was dysfunctional. So closing their eyes, clenching left fist, and then you watch, and then tell them, okay, open your eyes and relax. Close your eyes again, or even I will not have them open their eyes again. I'll just say, open your fist, now do your other side. And I'll watch and see if they're swaying a lot or they become more steady. Again, that's important, because then that's going to help guide you later on, stimulating those pathways more with some rehab. That's what we want to input and not do bilateral, but do one-sided for a while to upregulate that side, and then later maybe do something that's bilateral. So there's the clenching. And again, record it, Romberg more stable, or with right hand clenching, left hand clenching. The next one would be going to have them march in place with their arms out, supinated, and eyes closed. And you do this for about 20 seconds. And what I will commonly see is the person's marching here, and they're going to move forward. And then you say stop, and a lot of times they're shocked, they're surprised when they see how much closer they got to you. Again, if it's somebody who's falling easily, you got to be careful and spot them. You may put like a chair out there as a target, and then you can measure that and you be with them. Again, you really got to watch with a lot of these so they don't fall and get hurt more. Now, the big deal we're really looking for is rotation. But again, a lot of times tend to rotate toward the side where there might be the lesion. And it can be a little bit, or it can be dramatic, where they're turned this much. Again, the feedback is off. So that's a really good test I like to see. It's very dramatic to the patient too, that they thought they were marching in place and they rotate. You need to be quiet when you're doing that, because otherwise they can cue off your voice if you're talking too much. Or if I had like a space heater going, I'll shut off the space heater. So I'm not getting these environmental sounds that may keep them orientated and throw off the test a bit. So those are little extra things. I'm going to refer to some of my notes because there's so many things I want to go over and I don't want to miss anything for you. Also somebody, like when they're seated, you can also throw in there the pronator drift when they're seated too. Especially if someone older has had some problems or something, that's one of the ways you can test them without standing up. And doing it, their eyes are closed, they still may be drifting down. So that's a pronator drift because it's going into pronation on the side of the lesion. Tandem walking, most docs have been over that. Heel to toe, doing that in a straight line, doing eyes open, eyes closed. They'll tend to fall toward the side of a deficit. Doing walking on their heels, walking on their toes. Single leg balancing, which I've used this for a long time. I really like this a lot. The norm is a person should be able to stand single leg balancing for 20 seconds, eyes open or eyes closed bilaterally. And most of these tests take the shoes off. Have them take the shoes off, because if they've got a nice wide base shoe, it may hide some of the subtle imbalances. So make sure they're doing it with the shoes off. And so what I commonly would do, use a stopwatch on this, is I'll have them bend their leg back this way. And I'll time them eyes open first, And when they hit 20 seconds, I'll stop them. And then I'll tell them, next we're going to do it with the eyes closed. Now, if this is somebody who's had a lot of problems falling, really be careful. You may not even want to do it yet. Or if it's subtle tilting, then spot them really good. And again, you can tell them, we're going to start balancing on the right leg. I'll have you close your eyes and bend the other leg when you're ready. I prefer bending here instead of bending out and bringing it out here. There's another test we'll do with this. And this is a little easier and more consistent and stable because it depends where they put this leg. It may vary time to time. So when we do follow-ups, it'll be more uniform to just have them doing this. And time them. And there's a lot of time. Person can only stay up there 2 or 3 seconds on that. So again, this with a stopwatch will help, and I'll put down, can only do for 2.56 seconds or 5.5 seconds or whatever. And recording that. Ideally, we're shooting for 20 seconds. And the people, when you rehab them well, they're going to get up closer to that 20-second norm. Now again, if someone's got knee or ankle injuries, chronic or acute, this is not going to necessarily be very accurate, but you can put down, in your notes, they also have a knee injury or an ankle injury, and then see what the stats are like when they change later on. But I like to use this a lot, and it's worked out well to show I'm improving it. Tuning fork, the 128 frequency. Using this on the internal malleoli, bilateral, and the nail of the large toes. Now I'm going to tell a patient, let me know if this feels equal or if there's a noticeable difference where one side's lower. Record the deficit side. It's a lot, but they'll a lot of times tell you, I felt it more on the left, feel on the right. I'll still put down the deficit side, that the left side that was less sensitive, or they could feel it less on that side. So we're looking at, like on the nail on the toe, and I'll put my finger on the opposite side, stabilize, push down, and try to be uniform with your pressures. And then also on the tip of the thumbs. There's other more elaborate testing you can do, like on the distal radius, which would be a good spot too. So we're trying to test some of these columns in there and see what's going on. And again, some of the rehab you can change quickly. I had somebody did the other day, and it changed in one visit where it upregulated when we did some neuromuscular re-educational things. So either tapping it here, or that can get rough on the hand after a while, or you can do on your shoe, tapping on the heel, and then try to use the same amount of time between initiating the vibration and putting it on. Because if I go quickly here one time and the next time I take my time going the other side, it's going to lose some of the vibration. So those are those subtleties that can give you false positive findings. So try to use about the same time on getting to it. While they're lying down, do Babinski. Really watch for any subtle changes with the Babinski test. And then something you could have thrown in earlier when they're sitting is the alternate motions. There's many ways to do it. And the positive finding is this strange Greek word, the dysdiatokonokinesia, or something like that. So some people say, move your fingers like you're playing the piano, and you watch to see if both sides are the same or if one side's different. That's the lesion side if it's less. And then the other one is alternating back and forth, going this way back and forth, different ways. There's different ways of doing it, but there should be the similar rhythmic motion. I noticed with myself, after about 8 seconds, this side doesn't always move as well as the other side. And that could be different things. It could be tied in with my old shoulder injury, or it could be tied in with my cerebellum on that side. So again, you got to look at what all else is going on with somebody. Or they may have a shoulder or an elbow injury from like a car accident or a football injury. take that all into account in there. But that's, again, one of the things you're looking at. The body should be able to coordinate. That's what the cerebellum's doing, coordination. They should be the same. And if one starts going off, it's like it's not staying in the same spot, positive finding. Also, when examining, I like to watch the pupil, especially early on in first exams, and using a stopwatch. One, I'm looking to see, are they symmetrical and are the sizes the same? But then I like to measure with a stopwatch, how long did they hold that contraction? Because that's going to tell me about the sympathetic parasympathetic balance with them. And you see, I see some people, you put a light in them, that eye goes down and comes up, or it pulses. That's a positive finding. It should not be pulsing on you. You know, it should come down nice and tight and constrict, and then after a certain period of time it opens up. But if it's pulsing right away, that's a problem. And or they're not uniform, so use a stopwatch to record that. Now put down contraction duration to a strong light. Left side 5 seconds, right side 2.3 seconds, or whatever it was. So using that's another easy tool there. There are other cerebellar tests, and these are some good screening things you can do. There's also, like, lying down, the heel along the shin down of the foot to see how well they do that. Having them pick up their foot when they're lying down supine, moving in different directions. Do they have fine motor control? Do they, know where it is in space? Is it uniform? Are they able to lift it up, say a few inches, move to the right or the left the same? Is there a difference? And then you do your muscle testing too. I like you do your manual muscle testing, like per Kendall and Kendall, or the basic applied kinesiology, which is virtually about the same. But recording those, because if there's motor deficits that's not associated with direct injury, then we might have to start looking at the cerebral cortex on a certain side, or there's some inhibition. These aren't necessarily cerebellar, but again, there's other problems that could be going on. And recommend also, like Dr. Carrick's courses, if they have one on cerebellum, that would be worth doing, get more detailed testing and treatments on it. There's quantum neurology. Dr. Mark Pick has Mark Pick Creations. He's a brilliant friend of mine. He's one of our chiropractic neurologists. He has a lot of great visual aids. Get more education in this area. Also, checking eye movements. Looking around different ways. You can also use that as therapies. Like if there's some nystagmus, you can also use that as a training tool to help somebody, as an exercise neurologically. And then have the patient practice these also. Again, cerebellar test dysfunction tends to be on the side of the abnormal findings. Now, the pronator drift can sometimes be a lesion on the opposite hemisphere. So again, these have to be all looked into. Posture analysis. A head tilt, a lot of times will be leaning toward the strong cerebellar side. There could be other factors, but that could be one of the factors. Checking eye convergence. When we're doing eye convergence, it'll tend to be on the weak side, the abnormality. And checking a person's ability to focus, like what's going on. So you do some of the cranial nerve testing there can be of help. Larger pupil on one side, poor autonomic regulation of the cortex on that same side. The single leg balancing, problems on the side of the weak cerebellum. I've seen both. So you can have both cerebellum that's been down-regulated and affected. And again, as we do, rehab, we start bringing them up. You have to balance, because there's some patients I may be giving them some home exercises, like single leg balancing, building up one side. The next time I find the other side's showing weaker, and then have to bring it up a bit. So you may juggle it back and forth till they're more symmetrical, and then maybe doing, like, say, rocker board or other things which doing bilateral. So bear with me on this for a moment. Again, cerebral cortex could be a factor, again, with muscle weakness. So, example, if we have the incoordination showing up with the cerebellum, it'll tend to be on that side. However, if there's muscle weakness, like, say, a deltoid, okay, that could be medial deltoid C5 nerve root. There could be something happening there if it was from a whiplash, but it also could be the opposite motor cortex, could be a factor. So again, that's what you'll look at. If someone has incoordination with walking, just normally, suspect the middle cerebellum, that there's a lesion going on there. Muscles of speech, again, can be tied in with multiple things, but cerebellum can be a factor there, especially if there's slurred speech or abnormal enunciation going on. So these are some of the key testing. Another one is, can they identify different shapes with their eyes closed? And there's also, if you're trying to get nitpicky on some things, there's devices out here that there's different weights. And I would go with something noticeable, not that some of these are just slightly different, so many grams. But some are heavier than the other, and it should be noticeable. With their eyes closed, can they identify one arm and one hand at a time, which is heavier, which is lighter? So there's a variety of things out there. Online, there's some free tests you can do on the computer for reaction time. And that would be a good baseline that you get. And as you're working with them, you see, does their reaction time improve? Again, it doesn't cost you anything. You just get the software on there, or you just go to the website. You can just, like, do a Google search for free reaction time testing. And you can do that and keep a record of it. And see, is it improving? Again, you want to evaluate, document it, have abnormal findings, and be creative with your rehab to improve those deficits and get them as close as you can to normal. And there'll be some other things in electro I'll recommend and talk about them. So thank you for your time here. These are things I'm not going to be able to cover a lot, so I'm glad, to review them with you. Now, if you have questions on any things, when we get there, please let me know. Thank you.